thank you all for coming today. I really appreciate it. My name is Judy Campbell, and I work for the Office of Admissions and Student Affairs. And we were having a discussion about how to increase engagement and offer educational opportunities to the community. And just about that time, I got an email from the Tour de Cure that would I like to ride in a Tour de Cure this year. And I thought, well, this would be a really great opportunity to bring a topic to the nursing community, whether you are a bedside nurse or whether you're a provider. You are going to work with individuals who have type 1 or type 2 every day. I am now a type 2 diabetic myself, so this is also a topic that's near and dear to my heart as well. So we decided, and my new employee that just started a few weeks ago, she said, you couldn't have just started with just doing a team. We have training rides, we have the lecture series, we have t-shirts, we have all kinds of things going on. So this is a multifaceted opportunity for people to be involved. If you want to join our team, I would love to have you join our team. Or if you want to volunteer or you want to donate to the Tour de Cure for our students, we would love to have you do any of those things. I'm going to turn this over to Hannah. Hannah works for the American Diabetes Association. We started collaborating when she came to see me about starting a team. And I said, hey, how about something more like the lecture series? So we have been working together for the last several months putting this together. So thank you again for coming today.
Thank you, Judy. And I want to thank CU College of Nursing, especially for helping to put so much of this together. Judy has put so many hours into this, and truly our hope is that every single person in this room walks away from here today and is able to kind of improve their relationship with their patients and improve patient outcomes. So if every single one of us is able to connect with somebody with type 1 diabetes in a more positive way, then we've done our job here today. So if you haven't heard of the American Diabetes Association, I hope that you've been living under a rock, and that's the reason why. So part of the intention here today, too, is to kind of just go over some of the resources and programs that are available here in Colorado to make an impact and to support you as nurses. So at diabetes.org/Colorado, that's where you're going to find everything that we do here in the state and a list of our calendar events. We do boot camps with our Latino Initiative program. We have Camp Colorado, Camp Sweet Pea. Camp Kickstart, which is, so we have 2-day camps, one in Loveland and one in Colorado Springs for kids with type 1 diabetes. We have a week-long sleepaway camp, Camp Colorado. We also do other resources for providers. So every year we have a provider conference. We look to celebrate people living with diabetes at our Journey Awards, which we're going to do a dinner in Colorado Springs in October. So pretty much anything you can think of, we're doing here in Colorado. We do a lot of work with advocacy. We have a diabetes coalition that meets at the Capitol. We're working inside corporations to reduce the cost for their employees around diabetes, because as we know, this is a true epidemic. So over 400,000 people here in Colorado are living every day with diabetes. In addition to that, it's 1.3 million just here in Colorado, and we think of Colorado as an outdoorsy fitness state, 1.3 million people living with prediabetes. And those numbers are just astounding. So that's sort of our job alongside, nurses, is to really make an impact on what's happening here in our state. So I talked a little bit about this, but so how do you get involved after today? After we hear from the people who are truly the experts on type 1 diabetes, you can volunteer at camp as a medical staff and really get to know what it's like to wake up at 1 in the morning and test a kiddo who has type 1 diabetes, and they're just, their blood glucose is running high, and oh my gosh, they won't come down. So I'm gonna, as a med staff, get up and check them for the next 30 minutes, right? So 6 a.m. comes around, I didn't get any sleep. That's the life of a type 1 diabetes parent. We're going to hear from one a little bit later. We're also involved in research. So we have anywhere between 15 to 20 ADA-funded researchers doing their work right here in Colorado. So that's a huge kind of win for us, if you want to look at it that way, that we have those resources right here in our backyard. We have the Barbara Davis Center truly an international leader in diabetes. We also have, I talked about our advocacy work, and a piece of that is the Youth Ambassador Leadership Program. So we take 35 kids between the ages this year 5 and 17, and we basically train them as little PR agents so they can go out and tell their story and talk about what the ADA does here in Colorado. Also wanted to remind everybody about the other lectures that we're doing in this series, and I know it's summer and everybody's kind of in the summer mode, but July 20th is going to be exercise, diet, and diabetes, August 18th, and these are all going to be here. August 18th, type 2 diabetes, and September 22nd, which is 2 days before the Tour de Cure Colorado, is going to be diabetes in the underserved population. We're going to hear from the Dawn Clinic and also the ADA's Latino Initiative Program, which is doing a lot here in Colorado. So one more thing on the Tour de Cure Colorado, this is also kind of our other impact point for people who live with diabetes. So one of the coolest things that we do is we have the Red Strider program. So if you've been diagnosed with type 1 or type 2 diabetes, you show up to the Tour de Cure Colorado and you're presented a red jersey. On the back of the jersey, it says, "I ride with diabetes." So it's truly a celebration of every day that you live well with diabetes. On the back of the collar, it says, "I am why you ride," which is a reminder that the rest of us are here as your support team. So people who are living with diabetes, and this is what it says on the other arm, it says, "I am not alone." They are not alone in their fight with diabetes. So it takes a team. It takes organizations like the American Diabetes Association. It takes nurses. It takes doctors. It takes researchers. It takes parents and siblings. So it's truly a team approach, and that's what we're really here today to discuss. So I'm going to kick it off to Dr. David Wagner, who is involved in everything within the ADA. If you do start to be involved in the ADA, you'll learn very quickly that it's not just one thing. You'll drink the Kool-Aid and get sucked into everything that happens. So the panelists are laughing because they know they're also ADA volunteer victims. So Dr. Wagner.
Can you hear from this, or do I need that? Can you hear okay? Okay. So I also do Tour de Cure, and huge advocate. This will be my 4th. So I'm excited. I'm going to try to do the 100K. Okay, we'll see. I'm going to try. I'm really going to try. So thank you, Hannah and Judy. It's a pleasure to be here to speak to you. I'm going to talk about the work that we're doing, my group is doing in type 1 diabetes. We're type 1 diabetes researchers. I have been for about 15 years now. And I've been funded by the ADA a few times now, so I'm very proud of that. So, do I know what I need to do to get to my, okay. So I'm going to keep this low key, and if anybody wants to just interrupt, please do. Okay, so yeah, that's me. This is something that's pretty alarming, is incidence of both type 1 and type 2 diabetes. So breakdown based on age, less than 10 years, that's what we typically think of for onset of type 1 diabetes. But one of the things that's really alarming are the number of people over the age of 15 that are onsetting with type 1. The number of people in their 20s, 30s, 40s, 50s that are onsetting with type 1. The oldest person I've ever heard of is a 78-year-old woman in the UK, onset with type 1, and it was true type 1. So a quick point I want to make is, so I just had a paper accepted that's going to be published, and part of the undercurrent of that paper is type 1 diabetes more than one disease? And I think the answer is yes. I think a lot more researchers are beginning to think that type 1 diabetes actually is more than just one type of disease. I don't want to go into nitty-gritty details about why that's true, but that helps to explain from a clinical perspective why some people seem to do extremely well in their diabetes and other people don't do as well. And so I was mentioning to the panel earlier, from the clinical perspective, it's easy to blame the patient and say, you know, you're not counting correctly, you're not monitoring correctly, you're not eating correctly, et cetera, when it actually could be the disease state itself. So it's not a homogeneous disease, it's a heterogeneous, lots of differences, yes.
Add to that, because there's really important. When we think of the young patient, I have numerous friends for them. misdiagnosed with type 2.
Yeah.
And spent 2 years, on mental
Right.
meds and things like
Yeah.
that. Trying to do
Exactly. And actually, that's a huge point. So if you have a 5-year-old who's very thin, so a low BMI, and they fail a glucose tolerance test and they have blood glucose measured at 200 mg per deciliter, there's urine glucose, so what are you going to call it? That's pretty easy to think, well, that's probably type 1. So what happens if that 5-year-old happens to be 200 pounds? And you say, well, there's no such thing. Yeah, there is such a thing. 5-year-olds are now being diagnosed in the United States with fatty liver disease. 5-year-olds. Okay, this is insane. But is that overweight 5-year-old type 1 or type 2? What if it's a 15-year-old? What if it's a 30-year-old? And if it's a skinny 30-year-old versus an overweight 30-year-old? So it could be both. I mean, it could be either type 1 or type 2. How do you differentiate? Misdiagnosis, yes. So ADA reports that 33% of diabetes diagnosis are the wrong kind. So often, more than likely, it's going to be type 2 misdiagnosed as type 1. But it can go either way. So one of the things that we're concerned about is this increase over time. So type 1 diabetes over time, this is looking at, so 1980s through 2010, and notice an upslope. This is type 1, not type 2 incidence. So it's typically easy to blame type 2 on obesity or on food choices, but we know this isn't necessarily the case. There are genetics that are involved in type 2. I just got back from ADA Scientific, and there was a whole couple of sessions on the autoimmune components of type 2. So we never thought about that before. We always thought of type 1 only as autoimmune. They're both inflammatory diseases. It's inflammation. And they're both resulting in either loss of insulin or lack of insulin usage. So one of the things my group is interested in is identifying the cells that are attacking the pancreas in type 1. So these are lymphocytes, referred to as T cells. And what these cells normally do, so for those who don't know much about immunology, what these cells normally do is protect us from invaders like viruses, bacteria, whatever. But what they're doing in a type 1 diabetic is turning on the person and attacking the beta cells that produce insulin. So what's happening then is beta cell damage leading to loss of insulin production. So what we're interested in is what are the cells that are damaging beta cells and then creating loss of insulin. Okay, there's no cure for diabetes, type 1 or type 2. There are very few treatments for type 2. There are treatments for, type 1. For type 2, there's metformin. There's a couple of other things that are out there that have some efficacy, can be pretty good sometimes not as good. In type 1, there's really no treatment. I mean, insulin is a therapy. It's not a treatment. So what do I mean by that? I mean, insulin is not being produced, so we replace it. That's a therapy. It doesn't cure the disease. All the complications, it could be neuropathy, it could be cardiovascular, it could be muscular. All the complications that arise over time may or may not be due to hyperglycemia. And there's plenty of growing evidence. We always thought the complications were just because glucose is out of control. Okay, the retina doesn't like high glucose. So if the retina is continually bathed in glucose, there are going to be eyesight problems. This happens in both type 1 and type 2 diabetics. But the vascular problems, cardiovascular problems, both the type 1 and type 2 diabetic are automatically a risk factor for atherosclerosis, for instance. So cardiologists will ask you if you have diabetes. They don't differentiate between type 1 and type 2, by the way, and I know this is a friend of mine is a cardiologist. So they don't differentiate the types, but it's an automatic risk factor for atherosclerosis. There's now growing data, including some in my lab, that the atherosclerosis associated with diabetes is autoimmune components. So if we can better control that autoimmunity, we're going to be able to control, better control complications is part of what we're thinking as well. Okay, so once diagnosed, in the case of type 1, this disease has already been cooking, meaning the disease process in the body has been going on for a while. The cells that are attacking the pancreas, it didn't just happen one day. So the day that you were diagnosed is not the day the disease started. It was probably years, many years potentially before that. How many? We don't know. So why does the immune system begin to attack in type 1? We don't know. One of the other things that my group is looking at is a better identification for at-risk individuals. In this case, we mean type 1. So there are a couple of criteria that are available for that. I'll talk about that. Well, I'll talk about it right now. It's the next slide. So what are biomarkers? What are markers that might identify whether or not you're going to develop type 1 diabetes? So we talk about autoantibodies. Antibodies produced by B cells. An antibody normally would be against the bacteria, for instance. So when an autoimmune disease develops, there are antibodies produced against something in the body. In this case, there are 5 different proteins, and by no means is that the conclusive list. And I just want to grab people sometimes because we tend to focus on these 5, we call them autoantigens. So insulin is one of the autoantigens, and maybe that makes a lot of sense, and everybody goes kind of wonky over, well, it's got to be insulin that's causing disease. Well, it probably is involved, but it's probably not the only thing that's involved. Another protein called GAD, you don't need to worry about what the acronym stands for. It's a housekeeping enzyme found in almost all cells. Why is this an autoantibody in type 1 diabetes? We don't know. There are 2 different of those antibodies that have been identified. There's what's called islet-associated protein 2, and then a group here at the Barbara Davis identified zinc transporter 8 as a reliable autoantibody. So clinically what that means, you've got somebody sitting in front of you and they're hyperglycemic and you want to know are they type 1 or type 2, you take blood, you look for one of these antibodies. If you find one of these antibodies, you can say type 1. Problem is, not all people with diabetic have these antibodies. And somebody in this room who's not diabetic does have some of these antibodies. So what does that mean? Well, it's complicating the picture. The other thing that's highly associated with almost all autoimmune diseases are the HLA molecules. So for the clinician types, the clinical types, HLA, human leukocyte antigen. In research, we call them MHC, major histocompatibility complex. It's the HLA that with your HLA configuration, that's how your body decides whether to reject the kidney that you got or not. So we do HLA matching, that's tissue type matching. But the HLAs, specifically DR3, DR4, DQ8, DQ2, are associated with type 1 diabetes. So if you have these HLAs, will you get type 1 diabetes? Now, I'm DR3, DR4. By genetic analysis, I am really high risk for type 1, but I don't have it. Doesn't mean, not saying I'm not going to get it, but based on some work that I've done, I'm a pretty low risk because of another factor that we're going to talk about, we're going to look at. Something that's becoming more interesting, there's something called trans DQ8. And in almost all diabetics, a large chunk of type 1 diabetics do seem to have this trans DQ8 molecule. So what does that mean? Does that mean, is it something that we can use to predict? Perhaps. And what is its role in disease? I don't want to go into all the cell biology of that. But so these are genetic markers, and the other markers are autoantibodies. Again, still problems because not everybody with diabetes has any of those markers, and some people have none of those markers and still have diabetes, right? So it's still complicated. So my group is interested in a particular type of T cell that we originally described in mice, and then we moved into human studies. But these cells, they're CD4, so sorry, I'm trying to go, so CD4 here, CD4 is a classic marker for helper type T cells, the majority of T cells that are floating around in our body. And a molecule that we've been interested in for years is called CD40. And what we discovered is there's this population of T cells right there. They're CD4 positive, CD40 positive. And we discovered in mice that develop diabetes, these cells increase in the periphery of these mice over time. We can isolate these cells from a mouse once it develops diabetes, transfer it to another mouse, and that second mouse will develop diabetes. So there's pathogenicity. These cells are able to go into the pancreas and attack the beta cells. So we began to look in human patients to see if we could see these cells. So that was a very basic question for us. We went to the Barbara Davis. We did a blinded study where Barbara Davis provided us blood samples. We didn't know if they were type 1, type 2, or neither, because they could be any of the three. We ran our test and looked at what happened. And what we found is that by looking at this population of T cell, whether the person was a new onset, and in this case, a Barbara Davis new onset is defined as someone having diabetes less than 6 months, I think. Because we talk about new onset, recent onset, and then longer term disease. So new onset is less than 6 months, but we also had diabetic long-term patients. These were people who have had disease as long as 45 years. So whether they had just been diagnosed or had been diagnosed 45 years ago, if we look at this population of T cells, they're elevated compared to non-autoimmune, non-sick controls. In Colorado, so once upon a time, the diabetes world has flirted with islet transplants. It's been done twice now. It's been originally in the 70s, and none of that went well in the 1970s. But then in the late 1980s, early 1990s, a group in Edmonton, University of Edmonton, came up with what's called the Edmonton Protocol, a new protocol for islet transplants. There was quite a bit of early success. So recipients of islets in the Edmonton Protocol for 2 years were insulin injection free and were doing really pretty well. At 5 years, there started to be failure in the transplants, and by 10 years, it was almost 100% failure. So we thought we got it, but not quite. In the Denver Metro, there were 4 recipients, and we were able to look at those recipients, and at the point when their islets began to fail, their new islets began to fail, their level of this T cell was back to this abnormally high number. So here or there. Type 2 diabetics, again, not autoimmune, but turns out maybe. There could be some autoimmune components there, but typically not an autoimmune disease, but certainly hyperglycemia. And in these individuals, they look just like controls. So we can differentiate type 1 from type 2. At this point, we've looked at well over 400 type 1s. We've looked at about 200 controls. So in Denver and at this campus, it's much easier to get a type 1 diabetic than it is to get a control subject. And interestingly, it's easier to get a type 1 than a type 2 if you're on this campus. So, but we've looked at almost 70 type 2s at this point, range of ages, both genders. And we've been able to do matching, so we can age and gender match a type 1 and a control. And the differences remain the same. We've also looked at the level of these cells comparing to autoantibodies. So this begins to make an important point where I'm concerned. So these are pre-diabetic, okay? So pre-type 1 diabetics, designated by what's called a TrialNet protocol. So they may or may not have autoantibodies, but they have the genetics. So they meet criteria for disease. And breakdown based on 0 through 4 of the autoantibodies, TrialNet reports that if you have 4 autoantibodies, there's an 80% chance that within 5 years you'll develop type 1. And it turns out, according to ADA last week, the number's more like 30% chance. So there's several criteria that are involved. Statisticians have to get involved in figuring all that out. But what's interesting to me is there are some pre-diabetic individuals with no autoantibodies who still have an elevation in this cell subset. So we are following these people, and that's actually my ADA grant right now, is to follow these people through and see, do they develop diabetes and at what point might they? So this is another breakdown in pre-diabetic, pre-type 1 diabetic people. So they fall into a high, an intermediate, and a low category. And this is looking at the ability of their T cells to respond to human islets. So can they recognize the human islet and do something? And so these guys that are at the high level here do respond to human islets, which is what this shows. But individuals who are low, still meeting the definition for pre-diabetic, didn't respond to human islets. So my argument is that this T cell measure is a better predictor of who's going to respond to an islet and who may go on to develop diabetes. So that being done, one of the things we're interested in is controlling this population of T cells that's attacking the islets. And how we've done that is creating a small peptide. It's a 15 amino acid peptide that we call KGYY. I can explain why. I'll see if I have the slide, but you don't really need to know why. But this peptide targets the CD40 molecule. And so what we're trying to do is, our thought is, so we know we've got this CD40 expressing T cell population that's prevalent in type 1 diabetes, not in type 2 or controls. And if we target the CD40 molecule, what effect might that have on diabetes? Okay. Actually, I think I screwed up a slide. Oh, yeah. Yeah, okay. So what happened, so remember, there's a mouse model of type 1 diabetes. It's called the NOD mouse, non-obese diabetic mouse. And so what happens in this mouse is leave it on the shelf for 16 weeks, and 80% of female mice will become diabetic, 50% of male mice. Okay, those numbers don't translate to human. Human is almost 1-to-1 female to male. I think it's actually 52-48 female to male. With most other autoimmune diseases, sorry ladies, women are more likely to develop an autoimmune disease than men, with the exception of cardiovascular autoimmunity, and then men are much more likely to develop there. But this mouse, if left alone, will develop diabetes. So it has the genetics, it has the immune system that's prone to this disease, it has all the components to drive disease. So what we did was inject these mice with this small peptide. We did an IV injection once a week for 16 weeks. Injecting mouse veins is really, really difficult. They're tiny. They're really tiny. And in fact, people miss about 30% of the time. And so just for your interest, the way you do it, it's called a tail vein injection. So if you take a mouse by its tail and look around, there's one artery and 3 veins around the tail. So you try to hit one of those, and I've got a couple of people who are really, really good at it, and that's just a skill. So we injected the mice once a week with this peptide that targets CD40, and we looked at what happened. And what happened is, depending on the size of the peptides, there was an 8, a 10, a 13, and a 15 amino acid peptide. The reason it's called KGYY is because that section stayed the same in all those different peptides. But using that peptide, the 15 amino acid peptide, we were able to block diabetes in 90% of recipient mice. And at this point, we've done over 200 mice. And we're able to block disease in 90%. Now, it's like, well, why isn't it 100? In a biological system, I've never seen 100% efficacy with any drug, for one thing. But, you know, these are mice, and their genetics should be basically the same. As I said, the injection technique can be difficult, so you can miss. But what also happened is, so this C picture is it's a histological slide of the mouse pancreas. So this part here, right here, that's the islet. So histologically, pancreas is one of the easiest organs to identify because you can always find islets floating in a sea of tissue. And this blue here are T cells. So there, those are T cells that have moved into the islet and begun to attack the pancreas. Now, what's exciting about this picture is notice that there are only cells here at the edges of this islet. If this mouse were fully diabetic, that islet would be completely covered. There would just be a solid blue there. So it's a massive number of cells go into the pancreas and attack the islet. So with this potential drug, what we've been able to do is block the ability of these cells to completely attack the islet. So this section in B, it's called Insulatus score. So how many cells went into the islet and attacked? What you want to see is lots more of this white box, because that means 0. So the number of 0 in treated mice was much higher than it was in untreated mice. Then one other quick point, because this is impacting an immune cell subset, you want to make sure that you're not damaging the immune system. So one standard measure, we do this in people, we do it in mice too, is what is the CD4 to CD8 ratio. So when a blood test gets ordered, one of the things that's on there are lymphocytes, CD4, CD8 lymphocytes. So for instance, if you see an elevation in CD8 lymphocytes on a CBC, then that's going to suggest there's a viral infection. If you see an elevation in CD4 lymphocytes, the question is, well, what does that mean? I mean, it could be a lymphoma, a T-cell lymphoma, but it could be an autoimmune disease. So we're seeing that over and over, that population of cells is being elevated. So what's happening with this drug is the treated mice, their CD4 to CD8 ratio, and on average, CD4 to CD8 ratio is about 2 to 1. So if you don't have an autoimmune disease, you don't have cancer, you don't have an infection, your CD4 to CD8 ratio is going to be roughly 2 to 1. That's not an absolute with every person, but pretty close. Same is true in mice. So this is a non-autoimmune normal, which is the third box here. And notice that that's at about 2 to 1. So, but in mice that become diabetic, notice that number, the middle box, it's much higher. So what this drug, potential drug, did is stop hyperglycemia from developing, stop the islets from being attacked as much, and bring their CD4 to CD8 ratio back down to normal levels. Okay, so we could prevent, that's good. Can we reverse? Then that becomes a big question. So this is something we're very excited about. We took new onset, and we're going to do a lot more. I've got a bunch more grants going in because I got some really good questions about how late can we do this. So we took mice that were new onset diabetic. For a mouse, that means their blood glucose has got to be 250 mg per deciliter. So it's a 250. That's pretty high. But mice fluctuate quite a bit. So we want to see at least 250 because once they hit 250, they generally don't drop back down. So in a human, you don't want to see 200. In a mouse can be 200 today and can be 100 tomorrow. And it can stay at 100 and then go to 230. So, but once it hits 250, that's usually the cut point. So we took mice, 16 mice at this point, and we did this over several different time periods. As soon as they were diabetic, we started treating them with this peptide. So we did an IV, a bolus injection. So we upped the concentration above our prevention study, but we did every day for 1 week, and we continually monitored their blood glucose. And what happened is fairly impressive. Very quickly, some of the mice reversed their hyperglycemia. So they went from 250, and in most cases, we're talking about from 250 to 150. And so for a mouse, that's pretty good. We got several of them down to 100. and being continued to monitor. We were able to get 57% of them down under 200 and keep them there for up to 16 days. So a couple things we need to do is we need to look at later stage in disease that's on the docket, and we need to take this further out. So there's lots of, I've unwillingly begun to become a drug development expert, and it's quite a daunting task, and the amount of stuff that you have to do to get just to the point that you can approach the FDA to ask to do a clinical trial is really quite a lot. So good news here is we've done some pretty hefty doses in these mice, and we haven't seen any pathology based on treatment, post-treatment. So we've done a couple of mice at really high doses, and then we just let them go. In the prevention study, we doubled those mice lifespan. Now, I'm not offering this as an anti-aging drug. It's not, I don't think. But what I am offering is these mice typically would die from their diabetes, and they'll do it by age 30 weeks. So they'll be brittle diabetic at age 25 weeks, and unless you're pumping insulin in, and oh, by the way, I mean, we pump sometimes massive doses. Some of these mice are getting 10 units of insulin, which, you know, think about that. And the mice just like, oh, I don't care. So I'm not really sure what's up with that. But the mice will reach a point of insulin resistance. So, and at that point, we have to terminate experiments. But these mice that are treated, they will live as long as a garden variety test mouse, at least. So about 2 years. We haven't gone much past 1 year. And depending on the strain of mouse, because several strains of mice will develop tumors at about a year. But 2 years is about there. A 2-year-old mouse is quite geriatric. So we can get into 1 year and past 1 year. So we're pretty excited about that. So we can do all this in mice. Does it have any effect in human? Obviously, we can't put the potential drug, we'll call it, into a human at this point. But what we can do is test human cells. So remember the population of CD4, CD40 cells in mice that we showed were pathogenic in the mice. And I showed you the data that in humans that, with diabetes, there's an elevation in that same population of cells. So we took blood from type 1 diabetics, and we used this peptide to stain their cells. Can the peptide bind to the cell from a human being? And it does. And it does just as well as an antibody at binding. So this is a type 1 diabetic patient, and this is a blood sample. So an antibody to CD40 binds, and this peptide that targets CD40, preventing the disease in mice, binds just as well. So it does bind. What does it do? So one of the things that T cells do when they're going to attack and kill islets, create inflammation, is produce types of proteins called cytokines. And in particular, one that's highly associated with virtually all forms of inflammation is interferon gamma. So we examined human T cells for their ability from a diabetic, type 1 diabetic patient, and we exposed their cells to human islets and looked at their ability to produce this protein called interferon gamma. So very inflammation driving. So when there's islet exposed, the T cells made lots of gamma interferon gamma here, here. And if they were treated with the peptide, they didn't. They made much, much less. But another protein that those same cells produce, called interleukin-4, which is not in any way associated with inflammation, there was no difference in that particular protein. So suggesting that what this potential treatment is doing is causing these cells to no longer be pro-inflammatory. So we still got a long way to go from that. And that's basically the end of my talk. So I think what I wanted to give you some update on the work that we've been doing. and I'm more than happy to answer any questions about that. But if there are questions about type 1 that I might be able to go into, I'd be happy to try to address that too. So thanks. Questions?
Dr. Wagner, can you talk a little bit about how nurses can use this research and the information and one, continue to support research, but also use that when interacting with patients?
Right. So one of the things we have to do is advocate in the medical community. One thing, diabetes is more than one disease. So we've really got to get clinicians on board with that. I think it's beginning to happen, that more and more people are beginning to believe that, yes, this is more than just one disease. So there are multiple of these cell mechanisms that are possible to get you to the disease. So we've got to advocate for that. Two is there's lots of research. There's my research. There's lots of other people doing very exciting research. And are we close to a cure? I mean, I really am beginning to believe we are. Good question is how much time? That's hard to answer. I answer in terms of money, how much money. And the reason I do that, this project so far has about $4 million invested in it to get to what we have now. I think we're another 5 away from being able to approach the FDA. And going up the FDA is quite a task. You put together a huge package of all kinds of information, safety data and efficacy data and mechanism of action of drugs, things I knew nothing about 5 years ago. And you put together this package, you get one pre-meeting with the FDA and you sit down with somebody, actually you hire somebody to sit down with somebody, so somebody who knows what they're talking about, who sits down, presents the package, and FDA is going to do thumbs up or down. And if they do thumbs down, you're done. And so it's like, okay, thank you for your time, go home now. And all that money that got invested could be gone. So you really want to have a good package that's going to make sense. One of the things FDA allows is prove safety in 2 animal species. And although I think this is quirky, prove safety for X amount of time in 2 animal species, and then you can go into a human being for the same amount of time that it was safe for the animals. Now, what happens afterwards? People aren't really necessarily thinking that far ahead. I am. It worries me a little bit. But if you have something that's relatively safe, then you get to go into people. So we're actually hoping to get a phase 1A here at Barbara Davis that would probably involve 8 people initially. So, okay, I'm probably pretty much dodging the question. And I'm realizing that as I'm talking. So what, as nurses, can you do? Okay, there's hope out there, and quite a bit of it. The more that a person knows about their disease, it is adamantly my belief, the better prepared they are to approach it, attack it, and address it. So the more that you guys as clinical providers know about the disease, the better you are to help in the making of decisions, discussing with the person how to attack their disease. I mean, one of the things I'm astonished by, there's physicians break down kind of into 2, in my mind, into 2 groups. Those who really want to know the science. One, it's hard to know everything. So, do you subspecialize? Maybe. But there are those who really want to know the science behind it and try to understand disease mechanism. And then there are those who want to get as much done as they can and not necessarily know everything. But the more you know, the better prepared you are to help the person who's standing in front of you. And I think it makes a big deal. I mean, I think it makes a huge impact for people for it to not be sugar-coated, but to be factual, and to know that there's a lot of great research that's indicating very strong. I mean, this is 10 years ago. We didn't have this. So even if it's animals, and we can get an animal to no longer be diabetic, we're going to figure out how to translate that to people. So I think that's my answer. Yes.
I had a quick question. You said it took $4 million to get to the research that you currently have. How long did that actually take? Like
It's been
years?
about 10, yeah, it's been about 10 years.
10
No, it's
years.
been about 8 years. Bless you. It's been about 8 years in real earnest. And something that I try not to think too much about is, so the data where I injected the mice and prevented their diabetes onset, that was an all or nothing experiment. I had no idea if it would work. And I guessed at that peptide sequence. It was an educated guess based on, I knew the molecules that were involved. I was able to look up what the amino acid sequence was of those, where those two molecules intersected. And I designed a peptide based on that. And it turns out, I don't know why I made it 15 amino acids to begin with. I just did. I was sort of thinking about kite tails, that 3 of those amino acids are known to be interactive. And so there are 4 of them. And I was thinking, well, maybe kite tails matter. And so I put tails on either side of those 4. I picked the right size completely by serendipity, more or less. Let's say educated serendipity, but it was a guess. And it worked. And my experiment was, so I get yelled at by drug development people because I did it completely wrong. I did it completely backwards. They don't ever do this. They always start with a drug idea and they go into a bunch of cell types and they look for, does it do this in this cell and then this in this cell? And, you know, and I said, no, the hell with that. I'm just going to put this into a bunch of mice and see what happens. And if they get better, I've got something to work with. If they don't, I'm done. So that's the story. Yeah.
This research is largely preventative. If you were able to find pre-diabetics and treat them with this, would that be a lifelong treatment?
That's a good question. I don't know. I don't know. It really depends on what drives the disease. I mean, we know some of the drivers, we think, but the problem is everybody's disease exactly the same, and what are the real drivers? So is it always just going to be this T cell subset that I'm talking about? And maybe it's not, and maybe in some people it's not. So if we can turn the right levers at the right time, that might be enough. And it might be, if we can catch somebody, say, 6 months in a development period, and maybe they're still 2 years out from their disease, and we flip these right switches, it may be all that's required. That's going to take some figuring out. And it could be that it could be a lifelong prophylactic. My hope is that it's going to be a lifelong, not lifelong, it's going to be a treatment. So I was talking with some of the panel earlier, one of the things that CD40 is doing, it's on beta cells, that molecule. And I didn't show, but one of the things we showed, I'm sorry, beta, the beta cells. So one of the things we showed is if you engage CD40 on a beta cell, that beta cell will no longer produce insulin. Now, what was really surprising to us is it didn't produce mature insulin. So insulin so quick biochemistry lesson, it's created as a pre-pro hormone, so it's a long chain protein. There's an A part, a C part, and a B part. So clinically, you'll know about C peptide. So if you're producing insulin, you can take blood and measure C peptide. So if we're all producing insulin, we have C peptide floating around. So what happens is the whole chain gets cleaved at 2 points, and then there's the A chain and the B chain, and they're linked together by what are called disulfide bridges. So it looks kind of like that. And so that's a mature insulin molecule. So it's these 2 chains linked together, and then C peptide is floating around free. So one of the things we noticed is if you cross-link CD40 on a beta cell, it doesn't process out C peptide. So it stays in what's called pro-insulin. Now, pro-insulin is a little bit active, but not nearly as active as mature insulin. We need mature insulin for it to do its full job. Proinsulin has a tiny bit of activity, but not nearly enough. So if you're only making proinsulin, you're going to become diabetic by clinical definition. So one of the things we're interested in is, could this peptide go to the beta cell itself and block the signal that's preventing proinsulin from being processed into mature insulin? If that's the case, then we're talking about a reversal drug. So a drug at a point that could allow a beta cell to recover and make insulin again. Now, in the diabetes world, we believe that late-stage diabetes, most beta cells are dead, which there is evidence to support that that's true, but not all of them. And there's a group at the University of Missouri who's done a study showing beta cells can regenerate under the right conditions. So we used to believe neural cells, nerves, if they're dead, they're gone, that's it, forever. We now know that's not true. They're just slow growing. They can eventually regenerate. And so under the right conditions, controlling inflammation, beta cells may be able to regenerate. So we could be talking about true reversal. I mean, I want to be careful about that, but, and I'm obviously hoping that's what we're talking about, but we could be talking about true reversal. Yes.
I just wanted to clarify on something that you had said earlier. You said that if a patient has 3 out of the 5 autoantigens, or 4 out of the 5,
Yeah.
they say 75 to 80%.
Yeah.
But you're saying last week they said it's more like 30?
Yeah, so so the group that's really doing that is out of the NIH. It's called TrialNet. And I'm a member of TrialNet. A lot of people on this campus are. And one of the things TrialNet has done is what's called a prevention study. It's been going for a really long time. A couple of other things going on in Colorado, Teddy and Daisy. So getting newborns and following throughout life. And autoantibodies came out of that. So the caveat to it is age. If you're 5 years or younger and you have 4 autoantibodies, then 75% of those kids do go on to develop type 1 diabetes. As the person gets older, and so now that we're seeing this sort of explosion of type 1 diabetes in people over the age of 15, 30, for those individuals, all those numbers break down. So you can have four autoantibodies. If you're age 30, that 80% of those people don't necessarily go on to develop disease. And again, like I said, there are plenty of people throughout their pre-diabetes who do develop diabetes that never have any of these autoantibodies. So the caveat then was age, and that's what TrialNet was clarifying. And so if you consider all diabetics across the board and look at autoantibodies, then that number is going to come down to about 30%. But if you're talking about a population, so true pediatric population, 5 years or younger, then that number is going to be, the numbers are more true, about the 70, 80% development.
Any other questions? Thank you, Dr. Wagner. So before Ms. Sophia Meyer comes up, one of the things that we do, so the ADA is a health and wellness organization, is we have Get Fit, Don't Sit Day. So every 50 minutes, getting up and stretching. So really quickly, we're all going to get up and stretch. This is what we encourage, is for people not to be sedentary all day. And so up, and we'll just do a quick, like, over. Everybody's joints are popping, or just mine. Whatever. So kind of like around, some arms, kind of whatever you do in yoga, maybe not all the way, but pieces of it. Walking around and chatting for the next 30 seconds would be fine. All right. All right, and now we will hear from Ms. Sophia Meyer.
Okay, so I'm Sophia Meyer. I work at the Barbara Davis Center. I've been there for almost 4 years as a pediatric nurse practitioner. We have clinics all over the place. So I'm down in the Springs and in Highlands Ranch. We have some offices in Fort Collins. And then we do telemedicine where we see patients from Wyoming, Grand Junction, Durango. So we cover all of Colorado. People come to us from Nebraska, Montana, I don't know, Wyoming. Anyways, I've been a nurse for a little over 20 years and a nurse practitioner for 16. Only been at the Barbara Davis for 4 years, so diabetes is a little bit new to me. But every week I see about 30 plus kids. So when that's all you see all day, every day, you really learn it. And I think that's one of my take-home messages is that we have some funny stories of kids and interactions that they have with hospitals and dentists and things like that. So currently we see about a patient and new onset a day. So we were seeing about 365 or so new onsets every year. This year the numbers have gone up, so we're expected to see about 450 new onsets. We see kids up to age 18 and they're diagnosed as young as about 9 months. There are some kids that are diagnosed as babies, but typically they don't. They have a different type of diabetes. That's all I'm going to say, as much as I can explain it. So one of the things that we can do as nurses is understand what you're seeing when you're diagnosing kids out in the community. So, you hear about very thirsty, drinking a lot, peeing a lot, eating a lot. And before I came to Barbara Davis, I had never seen in my 16 years of practice before Barbara Davis, I had never seen a new onset type 1 diabetic. I'd only seen maybe a handful of kids with diabetes in the private practice where I worked. And so I had heard those things, but I didn't really know what it meant. And so one of the families that came in told me that their son would put their glass in the refrigerator where the water would come out and stick a straw in it and drink. That's how thirsty they were. So I would often ask, has your kid been drinking a lot or peeing a lot? And parents might think, oh yeah, they have lots of wet diapers. But the amount of drinking a lot and peeing a lot is just excessive. And I'll tell you that a lot of times it gets missed. Your kids have lost 20 pounds. And honestly, parents don't realize it. And a lot of times the urgent cares don't realize it because they're not seeing those kids. If you go to your own medical home, they should realize it, that your kids have lost weight. But parents, kind of blow it off and say, well, the kids have been, playing a new sport and they're growing. And so you'd be surprised at how often our new onsets get missed. They go to 1, 2, or 3 urgent care visits or EDs and they don't check a blood sugar. So kids might look like they have the flu. What else? I don't know, the garden variety virus that's going on. And if they did blood sugar, they would know. And so by the time they come to children, sometimes they're quite sick. So I think that's one of the take-home messages that we're trying to get out to the community, to providers and nurses. And I think for a while they had posters in bathrooms in the schools, the signs and symptoms that you're looking at, and to check a blood sugar. In my little clinic, I worked in a school-based clinic in California. I had a glucometer and I checked kids often and never found one. But just to be more aware of what's going on. What other take-home message did I have for you? So I think that sometimes we think of diabetes as a numbers game. You might know what an A1C is. Does anybody know what a normal A1C is? Anything below, 5. Anything below 6. And so you might meet a kid in clinic and see an A1C of 8 or an A1C of 12. And I just want you to realize that that number in and of itself may or may not really represent that kid. Not only is an A1C of 8 could be, they're having blood sugars of 60s and 400s and they're averaging out to somewhere of an A1C of 8. It could also be a kid that has blood sugars across the board of about 160, which is hard to find. But I just want you to realize that those numbers don't really represent your kiddo. And so to really understand your patient with type 1, you need to know a lot more than just that number, that A1C, or even that glucose. Even a fasting glucose doesn't tell you a whole lot for someone that has type 1. So what we do is we do pattern management, and when kids come in, we download their pumps or meters, if we're lucky, their sensors, and look at what their blood sugars have been for the last 2 weeks. Now, I'll tell you that at the end of school, when all the kids were getting out of school and they came in to see me at the end of May, I almost wanted to just tell them to turn around and go back, because it's the end of school, they're stressed, they're partying, you know, they're having parties at school, they're staying up late doing finals, even college students. So those 2 weeks don't really represent a good number for me to look at and try to help them make adjustments. But I have the wonderful benefit of seeing them every 3 months. Kids come in. And so one visit might not be the best representation of what's going on with them, but every visit I have with them, I'm getting to know them more and understanding their patterns. And really, that's the only way I think you can truly know and understand what type 1 is. I don't live with it. I don't have diabetes. And here's my plug for camp, because every year I go to camp and I spend a week with these kids, and it gives me a taste of what it's like for parents and for kids to deal with diabetes day in and day out. But as a provider, I'm trying to help them make good choices and adjust their dosing. The other thing I think that's important for you guys to know is that there's things that we can talk to with our type 1s that we should all be doing. I tell kids this all the time, but kids that are couch potatoes are very easy to dose because they don't do anything. So their blood sugars don't fluctuate as much. But do we want couch potatoes? No, we want kids that are active and exercising. And it really does make it much harder to manage their diabetes, and there's no formula. Like, they'll walk in and say, how should I give my insulin before my swim meet? Or I'm a wrestler, how should I give my insulin? Or I play hockey. And I can't tell them. Like, I can give them some suggestions, but they're going to have to just figure it out. You know, do you correct a high blood sugar before you play hockey? Do you have a snack? Are you going to go low? Are you going to go high? We don't know. And every sport they play is going to have a different effect on their blood sugar and on their body. So, but we want to encourage all of our patients, and especially our type 1s, to be active, because if you're active, your blood sugars are better overall. I have kids that come in and they say, well, we go to the park every day for half an hour, or rain or shine, we ride our bikes to school. And they do have better numbers and they do have better control. I don't think I'll go into it, but maybe I will. So there's different ways to look at diabetes for different age groups. What would you guys think? Like, what would be the most difficult age, do you think, to treat in diabetes when it comes to kids? Toddlers, yeah, and teenagers, yeah. So the teenagers are terrible. It's tough. And I say it starts at like 11. When they're pre-teen and pre-pubertal, they could be using, so we dose them by kilograms. And so you have like a 50, 60 kilogram kid come in, they could be taking 100 units of insulin and it's not touching them. Today, this kid eats 200 grams, 160 grams. He's giving that much, you know, he's giving 25 units before bed, and he still wakes up high. His body's just resistant. So they get frustrated. They feel like when they come in to see us, or anybody knows what their number is, what their A1C is, that they're getting, it's like a report card and they're under the gun. And so I'm a little lax with my patients sometimes. I'm not too hard on them because I realize how difficult it is. I live with 3 teenagers that don't have diabetes, and we barely function. So I don't know how you do it with diabetes, because it's hard to get those kids up and out the door just with the basics. And then these kids are dealing with their blood sugars day in and day out, and they never get a break. Toddlers are tricky too, because they don't do anything that you expect. They just drop, their numbers drop all of a sudden for no reason. And the other part is growth. You know, we see these kids every 3 months. And when I started doing diabetes, I thought, why? Why do we see them so often? Well, they will outgrow their insulin doses in 3 months. So if you've seen them in the hospital, If you've seen them in clinic and things aren't going very well, I think you can encourage them to exercise, to eat well, to see their providers, and to just do the basics, which I think they burn out pretty quickly. They've got to test their blood sugar, they've got to count their carbs, they've got to give their insulin, and different personalities handle it differently. The ones that worry me the most are the kind of OCD. They do a great job. They eat at 8, 12, 3, and 6. They test their blood sugars, but they're fanatical about it. And I worry about them emotionally more than some other kids that just live life and do the best they can, but don't get too crazy about it. We have 3 full-time social workers at the Barbara Davis Center, and I thought, why? Why do we need so many social workers? Every single patient could probably talk to their social worker because it's emotionally and mentally draining and challenging, and I think everybody just needs the support of nurses and school nurses. They drive me a little crazy too. And anybody that they come in contact with. So if you can be a support to your patients when you meet them, I think that's the best thing that you can do. And if you can go to camp, I run Camp Sweet Pea. We just did 3 days in Loveland. If you can go to a day camp like that, even for a day, and see what it's like for these kiddos, the diabetes part is nothing for us. I mean, it becomes really rote, and we do really well at that. But to just be a part of it and to see how they do, parents are crying to leave their kids at the door because they don't feel confident to leave them anywhere. They're panicked. They don't want their kids to be too high. They don't want their kids to be too low. They worry about everything. And so to understand emotionally and mentally what families go through, if you can spend a day at camp, I'll take you. It'd be great to have more people there. And then we do overnight camp, which is really what I loved doing the first time because I didn't get it. I sat there across the table from patients trying to understand how to adjust their dosing. It's not just, these many units per kilogram. It's very intense. It's, a lot of factors to take into play. And when you're at camp and you give a kid a dose and 2 hours later they're bottoming out or they're still high, you're racking your brain like, what did I do? What happened? And Johnny says, well, I went and I played, ball for an hour. And some kids go low when they play ball and some kids go high. Or Johnny had a breakdown, an emotional breakdown, and blood sugars went up. So you realize this is no easy thing to do. And you can sympathize a little bit more with families and understand what they're going through. I think those were my main topics. Any questions?
You talked a little bit about interacting with the patients themselves, but what's kind of the role of parents, and how do you try and do the same thing that you're doing with the patients, kind of the education empowerment piece with parents as well?
So I think you realize as a pediatric nurse that you're never just dealing with the patient, you're always dealing with the family unit. And it can be tricky because you've got all kinds of different family dynamics. You have kids where they want to do it all and parents don't really do anything, but I always ask parents to just be supportive. I feel, my personal thing, that parents should have some response, that we're a team. I have a little role in all of this. They come and see me every 3 months. Some call me weekly, upload their pumps and things like that in between visits. So for some, I have a bigger role. And kids, they're doing all of it, and I give them like a gold star. If their pump report shows that they're putting their boluses in and testing, I'm like, look at what you're doing. You're doing a great job. But then parents have a role too, and I think it depends on personalities and how kids and parents interact. But I think parents should be the ones to be monitoring those blood sugars, uploading their pumps, sometimes giving them, what's the opposite of praise? Sort of consequences, right? You have a kid. So I have parents that do a really good job of this. So a kiddo walked into clinic one day and he was testing 4 times a day and he was giving his insulin. And I said, what happened? You never test. And he goes, well, if I don't test every day for 4 days, I don't get the car keys. I'm like, oh, okay. So, that works for some parents. I had a kiddo walk into clinic the other day. I think she's 17. She was super excited. She's using her pump. She wears her sensor. And I said, "You're usually not so happy." And she's like, "Well, they said that if I'm managing my diabetes and I understand what I'm doing, I can go away to college." She's got 2 more years. And for the next 2 years, she's got to prove that she can do it. And it's the happiest I've ever seen her. And it made me happy to see her that way. So they figured it out. But every family has to work, in a different way. And a lot of people need therapy for help. I mean, there's a lot of just basic parenting that these families need, and we can't always provide. I told you the 3 social workers are busy every day, all day long, trying to help families work out some of these details. But don't judge these families. I mean, some kids really struggle. I think what you were saying about the different types of diabetes and understanding it, we don't understand that yet, but there's definitely some kids I'll say, you got it easy. Like, there's kids that can get by with maybe 10 units a day, and they still don't want to do it. But because who wants to inject themselves every day? It's hard. But there's some kids that can get by with just little bits of insulin, and there's other kids that need oodles of it. And so there's got to be different things at play, and we don't understand it, and we're just trying to deal with treating it. But it makes it challenging for those families. I mean, people come in tears. They're waiting for you to click the button to see that A1C, and they've been working so hard to get their numbers down, and then, it's still in the 9s or 10s, and you've got a toddler, and they see in their minds those long-term complications, and they're just panic-stricken about it. But all we can do is, try again and work on it for the next 3 months and see if we can get the kids in better control. And like we've talked, that A1C is what we use as a measure, but we really don't know, is that what's going to dictate who they're going to be, as a 40-year-old or 50-year-old, and what's going to be going on.
Said that if the family's managing the diabetes of their children very well, or the children are doing it very well, and the A1C is still really high, what is making that difference, that their management isn't, if it's spot on, let's say, is it that they're becoming insulin resistant? Is the dose not correct? I mean, is it multi-factor, or is it just like, are you finding, obviously everything's multi-factor, but like, what are the main things that could be affecting that?
Well, I would say that yes, it's all of those things, and probably some things we don't really completely understand. So, like, the 6'2" kid that comes into clinic, and he's literally taking 130 units a day, and is still at an A1C of 13. He's not missing doses. He's giving insulin. He's got a 1 to 3 carb ratio. So for every 3 carbs, he gets a unit, and that is a ton of insulin. And yet he's still not doing well. He's an active kid. So, I mean, there's some questions I just don't know. And I think it's going to take research and understanding more of it. When kids aren't doing what they're supposed to be doing, we pour on the insulin. We add more. There's definitely issues with diet, too. I don't think that we at Barbara Davis have a big pull in that direction. There's a couple of people that are doing some research. There are people that do low carb, paleo, and they do great. They have A1Cs in the 5s and 6s, but it's not something we as a center advocate. I can't tell everybody to give up donuts and things like that. And so we don't. We preach a balanced diet, fruits, veggies, but we don't tell them to get rid of all the junk. But those that do, they do excellent. I mean, there's a few cases that do extremely well. So I'm sure that there's multiple factors, and insulin resistance is part of it.
Do you guys try to use different insulins in managing for different kids? Saying maybe the 130 unit child or taking 130 units isn't getting affected. Do you guys try it different ones, or is that like, I know we do that in other medications, but I don't know if insulin's anything similar.
So there aren't that many choices out there. There's a couple, so we did a study, the type 2 department did a study with metformin to see if maybe some of our teenagers with insulin resistant would benefit from type 2 medications like metformin. And so we did quite a large study, and they found that they didn't benefit. So no, I mean, we encourage them to, to continue to be active and to do well, but it's so hard. A 4-year-old comes in and A1C's at 10, and mom's carrying a 2-year-old, and she's got her 4-year-old and her 6-year-old, and she's trying to manage diabetes. And I can't tell her she's doing a horrible job. I can't. I just have to tell her to keep doing it and working at what she's doing, and most kids do better as they get a little bit older and that they get a little more of a routine. But it breaks my heart because as a mom, I feel her, and as a nurse, I worry. Like, I see these kids in 30 years, and I think, I'm glad I won't see you because I don't know what you're going to look like, and it scares me. But we can't make them feel bad about it because they work so hard. So I can't. All I can do is encourage them.
Have you had any experiences with kids in your population withholding insulin for the purposes of weight loss?
Oh, yeah. So it's something I never heard of course, before I came to, and it's called diabulimia, which I didn't realize it had a name even. And the dietitians always pick it up sometimes before we do. But we had a girl was diagnosed in high school, and she went to a high school where there was 3 other girls with diabetes, and they taught her, like, immediately, don't give insulin for your high blood sugar. You'll lose weight, and, we'll all be part of the skinny troop. So, yeah, and I don't know if they all do it consciously. Some, I think, do. Some don't. They don't realize that they've been running A1Cs of 12 or 13 and really can't seem to give their insulin because they do gain a lot of weight. If you give insulin, and I tell the kids all the time, if you give insulin and eat a cupcake for breakfast, lunch, and dinner, you will get chubby. But you won't have, your blood sugars can be controlled, but that's not your best choices, right? So that's my take on it.
So now we're going to hear from our panelists. So we heard from an ADA-funded researcher. We heard from a type 1 diabetes provider. So our intention now is to hear from people who live with and interact with type 1 diabetes every single day. So this is sort of the opportunity. They're each going to share their stories, and then the opportunity is sort of for to learn, like, as nurses, okay, I have my time with a patient, and we're not in clinic, so I can ask you anything I want and kind of look at the approach and educational piece and what I can do to be a better nurse. So Chase, do you want to kick it off?
I'm Chase. I'm 17 years old. I've been diagnosed with diabetes for 11 years now. Living with diabetes isn't enjoyable at all, to be honest. But you just kind of have to deal with it because it's not going to disappear anytime soon, as far as we know. Makes everyday life a lot harder, makes it really stressful on me and my family. Making plans with, like, friends and scheduling around appointments is extremely difficult. So then, like, for, like, my worst care provider experience, just to help you guys, like, learn from it, it's really tough going into an appointment and waiting for 2 hours to see a doctor and then them finally coming in. But recently, like, diabetes is already an inconvenience by itself, and then add the 2 extra hours onto it really sucks. But recently, it's a lot faster, an hour maybe, if even that. So then the ADA has made diabetes much easier to manage for me, helps me know I'm not alone. I have a bunch of other people around me to help me with it. I'm a part of the Youth Ambassador to Leadership program, which she is as well, and so is Hannah. But I got to meet a bunch of other kids through it that are just like me, trying to figure out, like, what to do, how to do it, and all those sort of things. But if I had like one tip for nurses or whatever, I'd say when kids come in, don't lecture them. Try to be more understanding, kind of like what Sophia was saying. It's not easy to go in and then them tell you like, oh, it's your fault. Like, understand that they're doing their best to do like what they are. So yeah.
Cool. I am Daniel Schneider, and I have been diabetic for about 20 years. I'm a husband, I'm a teacher, I'm a bike racer, and a Red Rider. I definitely encourage you guys to come out for the Tour de Cure. And I'm also a patient here at the Barbara Davis Center here on campus. So I go to the adult clinic down the hall from where Sophia's at. And I'm a pretty low-tech type 1 diabetic. I don't use I have a continuous glucose monitor. It doesn't get used too often. I have never used a pump. I'm on multiple daily injections, which is a far cry from, I guess, what standard of care would be, at least in this country. But I guess that's a good point to make, just that like it works really well for me, and I've never used a pump. I've never been pushed to try it, and I've been pushed to try it. I should rephrase that. But I do really well with my management on multiple daily injections, and like the freedom that it provides me. So always worth getting that full picture, which some of our speakers have kind of touched at. Like, don't assume that like, okay, here comes this patient, we're going to give them this, and this. When I was diagnosed, it was about 20 years ago. I think the insulin Humalog had just come out. It was like one of the first like fast-acting insulins. And I want to stress to you guys that the words in those situations that you guys use matter a whole lot. I had an endocrinologist who was able to she probably didn't think about this at all, or maybe she did. Maybe it was something rehearsed. But I was 12. I was in the middle of 7th grade football season, and she said, oh, well, football practice is going to go so much better now that you're taking insulin. You know, now that you can actually use the carbohydrates you're eating, football practice is going to go a lot better. And it was such a powerful thing. It was probably just something in passing for her, but it was such a thing where it was like, oh, this is this thing that I do and I enjoy. I can continue doing it, and I can do it better now that I'm treating this disease, now that I'm working with this disease. Like I said, I'm pretty low tech. I don't acknowledge that I feel too much stress surrounding my diabetes. It's frustrating at times for sure. I commonly tell people, and this is completely belittling, or at least overlooking some of the struggles that I undergo and that a lot of other people with diabetes undergo. But I will commonly say, you wake up in the morning and brush your teeth. I wake up in the morning, I brush my teeth, I test my blood sugar, and I take insulin. And it's far more complicated than that for sure, but sometimes that's what it feels like for me, is it just becomes very routine. You get very comfortable, you get in a sequence or in a routine with it. And it's not something that has to be this huge burden or overbearing on your life.
All right, so my name is Kelsey Winger. I am in my 10th year with diabetes. I am an RN as well, and I have the pleasure of working with the Barbara Davis Center, specifically with pumps. I work with university as well here on campus. And my diabetes story, so when I was diagnosed, I was in between high school and college, and I really was going to college with no idea what I wanted to do. And I was immediately shipped up here to the Barbara Davis Center. I spent a couple days learning about diabetes. We had none of it in my family. And interacting with the nurses there is what really made me go to nursing school and to pursue this as a career. And I really wouldn't turn and go back and do it again. So I think my take-home message for nurses here is you are impacting your patients every single day. You are impacting their future, you're impacting their health now, and you're potentially impacting what they choose to do throughout their lives and who they choose to impact. I have been very fortunate to be very involved with the ADA. I think I'm probably the poster child for the Kool-Aid there, Hannah. So I chase kids around at camp with Sophia. I do Tour de Cure. I work with Chase as a mentor for our youth ambassador leaders. So it's really amazing to see these kids who have taken their diagnosis, their disease that they didn't ask for. They don't particularly want or enjoy, and their families are kind of in the same boat. And it's really amazing to work with them every single day and see them grow and see them be able to articulate to somebody what diabetes means to them. And it's really impactful, and it really makes me misty every time I think about it. But I think, diabetes is something that people have to learn to live with, not for. And so I do a lot of work as well with school nurses, and my biggest take-home message to them is similar to what everybody else has said. These kids, they work hard at it every single day, and making sure that they have all the tools in their bag to manage their diabetes, to live an exceptional life with diabetes, is the biggest thing that we can do for them as healthcare providers. So thank you all for coming. We really appreciate you being here, and it's a great thing you guys are going into. So.
My name is Kathy Hughes, and I'm the mother of 4, and I have 3 boys and a little girl. My daughter was diagnosed with type 1 October 29th of this last year, and I had suspected, I knew something was going on. I had seen behavioral changes that just didn't make any sense. I can vividly remember my husband looking at me and saying, "Who is she?" And I'm like, I don't know, and after her diagnosis, it all made sense. My hardest thing for her is that she's little. With her blood sugar, sometimes I don't know if it's her being 5 or if she's completely out of whack. We go to bed every night thinking about blood sugars. We wake up in the morning thinking about blood sugars. And what's hardest for me is that she wants control over something that she has no control over. And that's hard. And she's asked me, "Mom, how long do I have to have this?" And I don't know. Our 10-year-old, through the TrialNet, has 3 of the 5 autoantigens. That's emotionally for a family, I swear, I think I was in shock for 3 weeks. Even though I knew this is what it might be, you're never prepared for that diagnosis. And I think what I would want to empower you guys with, and with one of your questions, you said, well, if they do everything right, I can tell you altitude affects her blood sugars. Vaccinations affect her blood sugars. Emotions affect her blood sugars, none of which she has any control over. And it's a family affair. It's definitely, I grew up, my older brother's diabetic. He's had it for 45 years. We were told it wasn't genetic. I'm thinking they're wrong. He lost his eyesight at the age of 21 from the disease. He's 48 now. I've seen the impact. I've lived it. I grew up with a diabetic, and I thought I knew. I had no clue, no idea what my parents had been through. And I just don't judge, because you get what you're given. This is now our journey. And she's still here. We get to raise her and take care of her, but it's not an easy task at all.
Thank you. So now we're going to open it up for questions. And again, this is truly your opportunity. These are, there's no, docs here. We're all going to plug our ears. You can ask them whatever is kind of your type 1 burning question, but I'll go ahead and kick it off. So, and I don't know if everybody wants to answer this, but can you guys give an example of when you've had a nurse who really is a positive part of your care team for diabetes, and sort of what things that they did to really be a positive impact for you or your child?
Yeah, I mentioned that earlier. I had this endocrinologist that's just incredibly subtle. It was like, well, football practice is going to be a lot easier now. And that was it. That still resonates in my head 20 years later. That was that was something where it was like I had permission to continue doing whatever it was that I had currently been doing. And it was so small, but it was huge.
Sophia, she's my endocrinologist. So she's really good about not lecturing me, so to speak. She's really helpful in like making me seem like I'm doing a good job, even though it could be better, but I'm still doing the best I can for right now.
Sophia, I'm switching over to you tomorrow. And another person is Kelsey, quite honestly, because we pushed really hard after Brooklyn's diagnosis to get her on the pump immediately. And there was some resistance there. And I understand that it's a learning process, but at the end of the day, it's my kid. And so we had her on the pump within 2 months, and Kelsey was, our first trip we went away, was she on we forgot our insulin. I'm like, oh, God, so I'm calling Kelsey and she's like, where are you? I'll meet you. What mountain are you on? I've got, and it's just, for certain reasons, people are brought into your life, and you have been phenomenal to our family. So thank you.
So speaking of, I was switching to another question, so go ahead, Kels.
No, you're fine. Mine isn't super long. I just had an endo look at me very early on and say, yeah, this sucks. Like, this sucks. So what are we going to do about it? And that was kind of impactful because I had to get to a point where I don't want this. Like, who the hell wants to manage diabetes every single day? Not me. So getting to that point where the alternative, not so great. So yeah, it sucks, but what are we going to do to move forward?
So you guys kind of touched on this, but can you talk about the role of technology a little bit more? And as nurses, what are some things that, there's a million things on the market that people are or are not using. So what are some things that we can kind of educate ourselves about?
So I used the Medtronic sensor for a while, and that thing sucked. It was terrible. But now I have the Dexcom G5, and I love it. That's really nice to have.
How do you use that as part of like your, I know there's other people on your care team. How's that part of sort of your care plan?
Well, mainly it's just like, so it's Bluetooth to my phone. So then my mom receives all my numbers without me having to tell her bugging me about it. So that's nice. And then it before you never really had that constant line of where you are, but it'll show you every 5 minutes it checks it, I think, or something like that, and then just shows you what happens when you give insulin and what happens when you don't and how that works out.
Yeah, so I think I'm probably the only one speaking for the low tech, given that we had an advocate for a pump. I see a pump next to me, but no, I take multiple daily injections. I use a glucose meter. I have a continuous glucose monitor. I rarely use it. I find when I have the CGM on, it provides me a lot of learning, a lot of valuable information, but I start micromanaging. I start correcting if I'm 135, and rather than letting that just kind of play out, and maybe I would have ended up at 120 in an hour and a half anyways, but I was going up at 135, so I needed to do something about it. This works really well for me, just testing my blood sugar probably 7 or 8 times a day at least, maybe more, and depending on what I'm doing. We know there's a lot of things that impact A1C, no doubt, and I feel that I am kind of one of those people that's maybe blessed with an easier time keeping my A1C low or well managed. Using my antiquated 20-year-old technology, literally, everything that I take other than maybe Lantus was around 20 years ago. And I haven't had an A1C over 7 or 6.5 in 15 years. So I feel really comfortable with what I do, and I think that's an important thing. Don't assume that there's a one-size-fits-all approach. Make sure you have the full picture, understand the motivations people have when they're making the choices they do before you push someone in one direction or another. Maybe just come at it without bias and explain the pros and cons of different ways of managing diabetes with technology, because there's a lot out there, and I'm so excited when I see Google Life Sciences getting involved in diabetes management. It's going to be a really exciting next 5 to 10 years, I think.
So I just want to ask you a question. How many shots do you take per day?
I don't count because I don't care. It's probably at least 7 or 8. I mean, that idea of that taking 2 units now before I start eating, and now I've eaten and I know how much I've eaten, so I'm going to take the remaining 3 that I need to cover this whole meal. Like, the idea that I took 2 shots when I could have just taken 1 doesn't bother me, and I can't let it, because I know that that flexibility is necessary.
Absolutely. So I think that's super important, is to know what goes on in somebody's management of their diabetes and what works for them and what doesn't. So taking 7 to 8 shots a day, that is a huge time commitment, and that is something that everybody has to deal with diabetes at one point or another. I think we can all probably say that we've been on injections, right? So I think it's important to understand what somebody's comfortable with and how they manage their diabetes. My own so I use a Medtronic pump and CGM, and I like having it all in one system, and it's great to be able to sit on my pump. I also have it on my phone as well via Bluetooth, and so you have to have that conversation with your loved ones to say, my diabetes is still my diabetes. Like the phone call that says, you're low, are you checking? Maybe, I know I'm low, so how about, hey, how's your day? Did you have some Skittles in your backpack? Like, are you all right? So it's really important to understand that no matter what mode of therapy you use, utilizing your team as a whole team to support you is super important. And that is your provider and your nurse and your family and your siblings and your significant other and Joe Schmo down the street. So. And I think they had a bit of an older way of doing things. And in the last few years, because we've had so many newer kids coming, I mean, we see 3,000 kids a year. There's 20 of us, I think, providers, physicians assistant, nurse practitioners, and doctors. And the mid-levels see the majority of these kids because we're in clinic 5 days a week, and the doctors are in clinic 1 day a week. They're doing research the rest of the time. And so we have a little bit more say of what's been going on. And so if you get a family that comes in and says, I want a pump, they're going to get a pump. They could get it in. The only thing that slows them down at this point is insurance, which is awful. So Blue Cross can tell them that they have to wait 6 months. Some companies can tell them what pump they can and cannot use. So that drives us a little crazy too, because there's 3 or 4 out there, and I think families should be able to decide what they want. But we're getting kids on pumps within a couple, 2-3 months, and it doesn't matter how old they are. Parents worry that the kids are going to pull them out. They don't. You pop them on there, they get a little pocket in their pants or their dress, and they do just fine.
That's okay. For like sensor sizes or anything like that, is there any differences in that between age groups, or is it just straight across?
It's one size fits all, and the piece that's actually in this under the skin is tiny. So the piece you see on their body is big. Like a Dexcom can take over a toddler's entire butt cheek. And so they may only have cheeks for giving insulin. And so they have their pump on one cheek and their sensor on the other cheek. And then they're going to have to trade back and forth between the cheeks. And so that can be a problem sometimes. And adhesive can be a problem. I mean, there's all kinds of things that come into play, but we're going to work with them, and some people will take a break because they're tired of all that sticky stuff on them and go back to shots. But no. Just to tie into that, and this kind of brings up something that Sophia mentioned earlier, I get to work with pumps pretty frequently, and I've put a pump on a 5-day-old baby in the NICU. And then I have a gentleman who I think he's going to be 91 this year. So you can kind of run the gamut.
So Kelsey, since you're the resident tech expert, will you speak a little bit more about the trends in technology and what's coming out next, what nurses can look to see, and all of the changes that are happening really, really quickly?
Sure. Just briefly. So there are multiple different tech options for patients out there depending on how they want to manage it. So there are pumps that are just pumps. It's just a mode of delivering insulin. So it's a tube with a cannula under their skin, and they dial in their dose and their blood sugar and their carbs, and it delivers them insulin. There are multiple pumps on the market that are integrated with a CGM. So they're going to be able to see all of their continuous glucose, their sensor data directly on their pump screen, which makes it really handy for them to only have one thing to see. There are pumps on the market that integrate with a continuous glucose monitor, and then you use that sensor data to act on their blood sugar. So if they're having a low blood sugar, for example, and the patient, I always use the analogy of it's 2 in the morning, you've had a really long day, your pump is between your butt and the mattress, you have a snoring dog on the end of the bed, and you've got pillows and blankets, and you're not hearing any of your pump alarms, it'll take action to shut off your insulin. A lot of the trends going forward, what we were seeing with research and stuff, is looking at how do we create a closed loop system. So a external pump with a continuous glucose monitor that will actually increase and decrease insulin and learn based on your activity and your food and your exercise patterns. And so that's kind of our gold standard, is how do we make the burden of diabetes even less for patients. And there's lots of studies out there right now on a lot of that sort of technology. So it's really exciting to see that as somebody with diabetes, to say that there's something out there that I'm going to be able to wear on my hip that's going to take over management of diabetes for me. So that's kind of the gold standard of where we're headed. And it's awesome. There's a ton of articles on it right now. So there's been some publicity from, I think, CNBC. I can't remember what all outlets had some articles on all different kinds. There's the bionic pancreas, there's the hybrid closed loop system. So I would really encourage you guys to, if you're interested, read up on what's coming down the pipeline, because it's some super exciting stuff that we may be seeing in the near future. So.
Kind of piggybacking on the technology question, and this is kind of for the Barbara Davis people, have you noticed as people become more reliant on the technology, they become less aware of their body? Because I'm a low-tech guy myself, and I feel like I know my blood sugar within 10 units most of the time, and the more effort I put into technology, the more I kind of lose that sense of touch.
I like to think that there's some, like, I can't go on autopilot almost, but I mean, I don't have the contrasting view. So I studied nutrition and exercise science and biology because I wanted to know more about what was going on in my body, and learning about what the effects of exercise were on my blood sugar and how those two things impacted each other, and eating certain things. And I think that those are things that we have to be aware of no matter what. I remember the first time I saw someone typing in the number of carbs they ate into their pump rather than typing in how much insulin to give. And I was like, do you even know what's happening once you put that number into this technology? I don't know if it matters though. I don't know how that impacts an individual when they take that action versus dialing up an insulin dose.
Yeah, so that's something we always talk to our patients about, is how do you have an emergency plan? How do you have a backup plan? If you are in a foreign country and your insulin pump breaks, how are you going to manage your diabetes? And it's really important that patients still remember the basics. Still remember what a basal is, what a bolus is, how do I manage that? As far as your comment about feeling your blood sugars, I'm not sure that changes with technology so much. I think a lot of that is dependent on hypoglycemia unawareness. So the more time that you spend low, the less you feel your lows, which it could be on injections, it could be on technology, it could be with a CGM or no CGM. So I don't know. Do you have an opinion on that, Sophia? I can.
other thing that I wanted to talk about, and to everybody, so we've already talked about kind of the relationship between mental health, emotional health, and diabetes specifically. So you're all at sort of different stages in your lives, in your diabetes. Can you talk about like what is sort of going through your, so Chase, if you want to kick it out, like as a 17-year-old, you're looking to go to college, like what are some of the things that you're you're thinking about your diabetes, and when you're thinking about your management, and like how can nurses better empathize with sort of that day to day?
It's like, so going to college, it's scary because I don't know if I'm really ready for that. Like with how I manage it now, I don't know. It's a hard question to answer. I know that when I first got diabetes, it was kind of like, oh, what is this? Like, I don't know what it was. It didn't really bother me at all. But now it's more like, oh, like some bad things could happen if I don't take care of this now. So just kind of helping them like get that through their head early.
I was 12 when I was diagnosed, and I always say like 12 wasn't a time it was good to be different than people, than friends and things like that. And that I remember like my first day back at school, and my teacher had obviously told my classmates like, oh, he was diagnosed with diabetes, you guys have to help him out and look out for him. So like first day back, I'm drinking like a Coca-Cola with my lunch, and 12-year-olds probably shouldn't have Coca-Cola with their lunch, but I was. And one of my friends was like, you're not supposed to drink that. And I was like, well, yeah, I am. I need, this many carbs for lunch. And I just like immediately like shut down. It made me really frustrated. And I was asking Chase earlier if his friends knew he had diabetes. Do all of them know? How do they react? How do they interact with that? And honestly, like through middle school, and only my closest friends in high school really knew I had diabetes. I really internalized everything, which is not good. You definitely want friends. You want people who know, people who can look out for you. But at the same time, it served me some benefit because I became really independent with it. And I was lucky to have parents who kind of were able to say like, okay, you got this, like go and like figure it out. And I really independently managed it. I really internalized everything. I really took care of everything without a whole lot of input or discussion. And it really wasn't until I was probably 20 or 22 that I kind of became comfortable being diabetic and like talking with people just like as part of conversation, or testing my blood sugar when I was out at dinner, rather than like going to the bathroom to do it or doing it under a table, which is something that you guys might find as nurses. If you're dealing with new diagnoses, people come with a lot of different ideas. Some kids, I'm sure, like day 2 are just going to be like, okay, I'm diabetic now, like these are the things that I do, and they'll go tell their friend about it. But other kids are not going to do that. I was part of a cycling team called Team Type 1. It's now Team Novo Nordisk, and they had like very elite level cyclists and professional level. And that was really, through that avenue, was really kind of where I found my voice and my comfort being able to talk about diabetes. And it was also just, I mentioned earlier that words matter. And there's a lot of debate, or people get really frustrated if you say, you're diabetic, or I'm a diabetic, or something like that. Like, because diabetes doesn't define you is the common thing. You're a person with diabetes. And I'm going to kind of give a counterpoint to that. Like, I would never say I'm a person who's a bike racer. I say I'm a bike racer. And I don't view being diabetic as a negative, so I'm comfortable saying I have diabetes or I'm diabetic. But as practitioners, or as somebody who doesn't have diabetes, it's not up to you to decide whether it's okay to say you're diabetic. Like, that's not your role, that's their role. So I mean, I think there's a lot of conversational things, the way that we frame talking about diabetes, the way that diabetes is still the punchline of jokes in common culture, that needs to continually be addressed. And I think that you guys, as some of the first people kids might interact with as people with diabetes or newly diagnosed, gives you guys a lot of power to impact how that conversation goes and make sure that they're confident young people with diabetes.
Just to tie into what you said too, I think, granted we're 7 months in now, and we're in a transition with her where she wears a pump and people can see it. So they know. And it's we want it to be secondary to who Brooklyn is. She's a 5-year-old spunky little girl first, and diabetes is second. And that's one of my struggles, and my husband's struggles is, people are like, get a dog. And I'm like, well, how many things do we need to do that are going to make her different? Like, we just want her to be who she is. And, I think having a pump doesn't give her the choice to tell people, because then they know. We've kind of gone back and forth on that a little bit. So I God knows what battle that will be down the road, but that's where we're at with being 5.
I alluded to mine a little bit earlier. So I was diagnosed June between my senior year of high school and my freshman year of college. And I got diagnosed, and I think my parents have each maybe given me a half a shot, because I'm pretty sure they did not do a good job. So I really had to own it from day one, but I also had to own, I'm starting college. I am 18 years old. I am moving 7 hours from anybody who knows I have diabetes, and, well, shit, this sucks, right? Like, I don't want to deal with this on my own, and now I'm different than everybody that I'm going to college with, and I don't want anybody to know because I don't want to be different. And I was really, really angry for a long time. And it took me a long time to be able to I told my roommate in my dorm, obviously, because, safety reasons, but to really be able to look at somebody and say, I have diabetes, and I'm sitting in the dining hall with my insulin pen, and this is what I'm doing. It took a really long time. And so I think emotionally, it took amazing nurses, it took amazing counselors, to really be able to say, okay, what's the alternative? So I think the emotional part of it is, really love on these kids. Really, if you see somebody with diabetes, give them a hug. Tell them you're doing great. Give them a high five. The ADA's kind of thing is health and high five to stop diabetes. If you see somebody who's a red rider, congratulate them, because that's something that they're owning, and they are able to say, yes, I have diabetes, and this is what I'm doing about it to others. And so, so it's a good journey for sure. I wouldn't give it back. Yeah, so it definitely, I think, and that's a great question. If I had gone on a pump right away, well, my first pump I ever went on, I went on because it had no tubes. I was on an Omnipod for a really long time because I didn't want anybody to see it. I don't want somebody to know. And for those of you who aren't super familiar with everything, so there's several pumps on the market. You have tubing, you have not tubing. I chose a pump that didn't have any tubing because I could put it under my clothes, and I had a little device that looked like a cell phone that controlled my diabetes. And so I didn't really have to tell anybody. And so I think that it was great to go on a pump. It helped my diabetes tremendously, but it also was another avenue for me to say, I don't have it, nobody has to know. So yeah, I mean, I think you have to get to that place emotionally, for sure. Mm-hmm.
The questions? Okay, so just a couple more slides. I just kind of want to bring it back to sort of why we're here and what the next steps are and what you guys can do as nurses. So we talked a little bit about what the ADA does here, and now you've sort of had this perspective from people who really live with diabetes every single day at different stages in their lives and different places on their journey with diabetes, because it truly, as we've heard today, is a journey 24/7, 365 with diabetes. So one of the things that the ADA provides is we do have a lot of continuing education. Dr. Wagner alluded to the scientific sessions that just happened. The ADA writes the standards for diabetes care. So the scientific sessions is a true coming together of the greatest minds in the world around diabetes and kind of what's next, what's happening, how are we going to find a cure, and in the meantime, improve the lives of people who live every day with diabetes. So these are just some of the things that the American Diabetes Association does provide, including educational programs, and a lot of that happens here, but like I said, across the country. So online programs, if you guys want to discuss this more, you know, I'm an open book. I'm a resource for anything happening here in Colorado, but diabetes is primary. We are actually having 2 of those sessions coming up here in Colorado. Some more live programs, small on purpose because all of this is available online. And then Diabetes Pro is sort of our center for other professional resources within the American Diabetes Association. So these are just some resources for you as a nurse, but just as a message sort of from the ADA, what I would encourage you to do is listen to these sort of messages of empowerment and go out and connect with these kids and adults of all stages of their lives living with type 1 diabetes who you may interact with in the grocery store. And just share that message and the resources that are available. We talked about the Red Rider program. We talked about Cure Colorado. We talked about the day camps, the week-long sleepaway camps, the opportunities to volunteer, to serve as a mentor, to serve as a youth ambassador. So of all ages, there are things to improve the lives of people with diabetes while we fund research and look towards a cure. So thank you for being here. I hope this was helpful. There's going to be a Survey Monkey going out, so please fill that out so we know for the next one kind of what we can do to change and improve. But thank you for being here. And there's most important piece, I think, really, is that there's food out there.
No, he's an immunologist. I study fat and glucose. Not mice.